join me in welcoming her, and she'll help us lay the vision of telemedicine in our region.
Great.
Thank you.
Thank you. Thank you very much. It's a pleasure to be here. So what I want to do is just provide sort of an overview of where telemedicine is these days, and hopefully provide you with a bunch of resources that you can go to kind of promote telemedicine and make it happen. That way, I have no relevant interests or financial interests to disclose. This just came out last week, and it talks about the 5 top trends in digital transformation of healthcare. And if you look at it, this is all sort of involved in telemedicine and telegenetics and any of the tele-specialties that you want to utilize. And it really gets to the fact that what healthcare really is becoming these days is IT. And IT is absolutely going to be critical to promoting a lot of the things that Ronnie's been talking about, to getting, what the previous speaker was just talking about. I mean, how do you get all this information into the EHR, let alone trying to set up a telecommunications network that's going to join people across the states. So what's driving all of this, aside the fact that you've got all these nerdy engineers coming up with all this stuff to torture radiologists and clinicians and geneticists with the EHR and leading to burnout and all that? Well, there are a lot of things obviously driving transformation in healthcare. Let's forget about the political level. Let's talk about reality. A lot of it has to do with sort of the mantra of those of us in telemedicine is getting care to everyone, anytime, everywhere, in the easiest, most efficient, and effective way possible. Now, a lot of what's driving telemedicine in general is the fact that if you look at something like this, which kind of outlines the change in the healthcare population over the years from about 1850 to now, part of the problem is that this yellow band here, which people tend to think of sort of as the key provider base, essentially hasn't really changed all that much. The number of physicians that we have, basically because the number of medical schools and graduating classes, is pretty much been constant since about 1850. But what we're getting is a lot of other providers, including those in the field of genetics, which has arisen obviously since the 1850s. But all of this is leading to new opportunities to provide care in new ways. And so when we talk about telemedicine or telehealth or whatever you want to call it, mHealth, eHealth, there's all sorts of terms out there. A lot of times what we're talking about is trying to bring in other types of providers than your traditional MD or DO to be able to help provide services out to the rural communities, and then often as necessary connect back perhaps to the traditional base of providers. Other things that are driving things, what I call the scary acronym soup. And it's just a fact of life. There are new metrics out there. There's MACRA, there's MIPS, there's APMS, there's all sorts of stuff. Now, some of these, one of the major ones actually just got pushed back to 2019, clinical decision support, which is going to be a life-saving for a whole lot of people. But this is driving part of what we're all concerned with, is quality in care and access to care. And again, providing care when it's needed, as it's needed, to keep people in their home region. This is kind of a picture of before and after. This is specifically Emory, but I think a lot of programs, hospitals, and so on have looked at things in this way. Just 10 years ago, growth and expansion was all about growing by being bigger, sharing exams, strengthening service lines, and so on, but going out and gobbling up other practices and extending your reach. What we're talking about now in terms of growing and our growth strategy is getting better. And I think that's where telemedicine can come into play in healthcare in general and in genetics as well, because what we're trying to do is increase the share of covered lives, get competitive outcomes, improve outcomes, minimize costs, and assemble networks of providers rather than just 1 or 2 points of focus for patients, because a lot of the patients that we're talking about have comorbidities that extend beyond one provider. And in genetics, it's the same way. You've got patients who might need, genetic counseling, but then there's going to be psychiatric counseling perhaps, or mental health, behavioral health, and so on. Just many more implications. And if we don't provide the infrastructure for people to communicate and get together, you've got a fragmented patient care continuum, which just doesn't work. Some of the things, again, that are driving telemedicine and helping things is licensure compacts. Telenursing is far beyond everybody in this respect, being able to get licenses that cross state borders. But cross-state licensure for physicians, the compact agreements are increasing. And as of now, there are 18 of 22 member states that are actually actively engaged in this, which is great. And other specialties are looking at these cross-state licensure compacts to be able to allow providers, for example, to sit in Georgia and provide care to patients in Tennessee or North Carolina or wherever without having to worry about getting specific license for those specific states. It's their compact agreements. This is a report that came out earlier this year from the GAO, and there were aspects of it that were really good, and it looked at telehealth and remote patient monitoring in some of the selected programs. And what they did was they surveyed a variety of associations representing providers, and then 2 patient associations as well. And they asked them all these lovely questions about telemedicine, telehealth, and remote monitoring. And these are the core questions, how do you think it's going to help with alleviation of provider shortages and convenience and cost reduction and all this stuff? And they came out with all these themes. And it's like, well, to some extent, thank you, Captain Obvious, but we've been talking about this in telehealth for over 20 years now, that these are our goals. We don't need the GAO to come and tell us that the problem is there's provider shortages and patients don't have access to health care. So nothing against how they're spending our tax dollars, but it does make you wonder sometimes what they're spending our tax dollars on, because telemedicine is a train that's already left the station. I mean, it's gone. We have crossed the tipping point. We are there. And in telegenetics in particular, there are any number of studies that have been done and are being done to demonstrate not only that it's feasible, but that there are solid outcomes. And if you look at the literature these days in telemedicine and telehealth in general, there's 2 key journals, Telemedicine and Telecare and Telemedicine and eHealth, that have traditionally been the repository for the majority of the telehealth literature. And for each one has been in existence for just over 20 years. And you can review those to find any number of articles, quite a lot on telegenetics. But now, in the past 7 to 10 years, increasingly you're finding more and more articles on tele in subspecialty journals. And more often, what a lot of us are trying to get across is the fact that it's not tele. We don't need this tele in front of everything. It is just another way of doing care. And that's what those of us who are really in the field are trying to get across. It is not a subspecialty. It is not something different. It is simply utilizing modern technology to provide health care in the ways that we always had. If you were at the workshop this morning with the pediatric one, it kept reiterating, it's just the same thing that you do in person. You have to take into account that you're not, but it's the same thing. You're interacting the same way, getting the same information. It's nothing new. So again, there's a lot of studies in a variety of areas of telegenetics that again are proving that we have good outcomes. And this one in particular looked at a whole variety of things on patient satisfaction and psychological outcomes on those that were receiving telemedicine versus not. And overall, on all the metrics that were there in terms of provider satisfaction, patient satisfaction, feeling at ease after the encounters and so on, everything was absolutely positive and in favor of the telemedicine group. And as you can see, before counseling, people had a little trepidation about perhaps how easily you could talk to a counselor via tele or how adequate you would be able to pay attention. But then after the counseling, all of the scores went up in the telehealth group, that people really had no problems utilizing tele as a way of communicating with the genetic counselors. They were comfortable. They would be willing to see the counselor in person on a second occasion. but many of them said that they'd be willing to do it telemedicine, and that the quality of online counseling with in-person was incredibly high. So in many respects, what we're seeing is that genetics, all sorts, can be done by telemedicine, that the quality of the interaction is good, that you can use any combination of store and forward or just plain photographs and real-time interaction for a good number of conditions. There are a couple conditions or circumstances that it might be unwise to do it. For example, if you actually have to require palpation in order to figure something out, neurofibromatosis, Beckwith-Wiedemann, and hemihypertrophy. There are a couple that were mentioned this morning as well. But as long as you know that in advance, or are willing to refer the patient back to an in-person, you can still do an awful lot of an encounter via tele. And as you can see, the quality of the photographs and the information that you can get simply with a digital camera these days is incredible. And you can send some of this information. There are sites that are doing this, and it really is incredibly easy to do telemedicine. It takes logistics, it takes personnel, it takes champions. But once you get things in place, it really is quite effective. Now, there are a variety of models of telemedicine that you can do. One of them is an example by Oregon Health Sciences University, where you've got an academic base doing sort of a hub and spoke model where they're connecting up to different sites through their academic practice and providing telegenetics counseling. And that's probably one of where most of telemedicine started, was in academic institutions. And this is just an entree into their website, gives you a brief introduction as to kind of what it's all about. And then as you go further down on the link, it shows you how to connect up and make an appointment. The ECHO model, which Ronnie referred to before, is a program that was developed at the University of New Mexico by Sanjay Arora. And essentially it's a way, it's like tumor boards, in a sense. Where it's physicians getting together with other types of clinicians and so on to discuss cases in real time, as well as provide some education. Patients typically are not involved in this model, but you've got, for example, your geneticists, maybe your neurologists, you've got your primary care physicians, your nutritionists doing sort of a grand virtual tumor board get together, and you talk about cases, review cases, and then the expert in that particular area would also throw in some educational didactic information. And you can apply the ECHO model to just about anything. Those of you who are interested in it, you can go to the website. They do training. You can go to New Mexico, great place to go, especially in the winter, and or right around when they have the balloons. Or the hot air balloons, that's also a good time to go. But they will train you on how to set up and run an echo clinic. Very popular. They are reimbursable, I mean the whole 9 yards. These have been sort of endorsed by the federal government to some extent as being very effective. There's also sort of the direct-to-consumer. There's pluses and minuses about this, and people have very strong feelings about it. But there are companies out there who are recruiting professionals to engage in direct-to-the-consumer. In this model, the patient goes on to the website. The company takes care of credentialing. The providers in all of the states taking care of all the legal, the billing, et cetera. The customer typically just swipes their credit card from their home and can do something like this. They might send in some genetic, swabs and so on, but they also do provide counseling. Again, it's a model that's out there. Whether or not you approve of it or like it is really moot at this point because, like I said, they're out there and they're growing in all of telemedicine, but in genetics as well. A little bit about evaluation. Telegenetics and telemedicine in general poses a dilemma. To some extent, we've been held to a higher standard than everything else. People want telemedicine basically to solve all the problems in the world, cure cancer, cure any genetic disabilities, cure all rehab problems, and so on. And we keep stressing, no, we can't do any of that. It's not the miracle cure, the silver bullet. It is simply another way of providing care. That we are not going to all of a sudden, relieve somebody's PTSD or something simply by connecting up with them via tele. It's going to take the exact same process and potentially time that it would have taken on an in-person counseling basis, but what we're doing is providing that care perhaps sooner than that patient could have gotten care, or providing that care to patients who never would have received it because they're out in too much of a rural area. So when we publish results in telemedicine, you have this dilemma of, are we proving that our specialty works, or are we demonstrating that we have outcomes specific to telemedicine that would improve care? And what those who are doing telemedicine typically argue is for that latter set, that we can increase the number of consults, we can reach out to patients, and so on. The American Telemedicine Association has a whole variety of practice guidelines that are available for those doing telehealth. The ones most particular to this group would be pediatric, that was just released on how to do pediatric in general. A lot of the telemental health ones I think are applicable to this field as well. There's one on telepresenting, and we have been approached by a group to develop a telegenetics one as well. We're going to be pursuing this in the fall, so we will be working on that as well. The Heartland program has a telemedicine manual for how to do services and so on. You can go online and download it. It's a wonderful document. The American College of Medical Genetics and Genomics, they've also created a white report that's very useful to read, has a lot of suggestions in there, recommendations to do telehealth. On the ATA website, we also have these quick guides. People are always, I don't know what to do in front of a camera, or, where do I look? How do I do it? Again, the American Telemedicine Association can provide you with things. This is something our human factors SIG just came up on. One of the key problems that we encounter in telemedicine is simple eye contact. People tend to look at the camera, not the screen. If you want to look at your patients in the eyes, you have to look at the screen, not the camera, and vice versa. So little guides like this. We also have created a guide for patients to teach them about what the heck is telehealth all about. And all of these are freely downloadable, or you can contact me and I can just email them to you. But hand out to your patients or put them in your waiting rooms. Here, this is what telehealth is all about. This is what you need to do and need to be aware of if you want to engage in telehealth. I would argue, and a lot of us would argue, that the best way to do training is to integrate telehealth into our curriculum. Nursing schools, again, are far ahead of everybody else in doing this. Med schools are slower, but they're getting there. Osteopath are somewhere in between, and the allied health specialties vary kind of by specialty. It's scattered throughout public health, medical or management information systems, informatics, and so on. A lot of the accreditation boards are stepping up to it, but we need to educate them about how to educate our future providers by getting it into the curriculum and promoting health literacy. Training in telegenetics in specific, UAMS Arkansas has a wonderful program. University of Hawaii, Sylvia Mann, we've worked with her through the Southwest Telehealth Resource Center. We were starting to work on her module program that they're developed strictly from the tele side. There's a lot going on in this field. One way that we've done training, we originally did this with Hawaii, Arizona, and Arkansas, a three-way kind of connection, where we would bring people together. The didactic lectures were given, some by Arizona, some by Arkansas, some by Hawaii, to participants in each of the three locations, all tele, simultaneously done. And then in each individual site, and here at the Arizona, what we did was we did simulations for the rest of the afternoon. We had a group of about 10 people. We've done this a number of times, but you take about 10 people, nutrition, geneticists, whatever their background was, but all involved in telegenetics. Each one had to be a patient, each one had to be a counselor, and the rest of them would observe, and they rotated round robin throughout, so everybody experienced how would you feel as a patient in a tele-encounter? How would you do it as a counselor? And then they rated. And then afterwards, we all debriefed on what to do and so on. In terms of metrics, the Telemedicine Association also has a document, again, that I can provide. It was developed for mental health, but it provides about 30 different outcome measures that you can look at in telehealth, from provider satisfaction, integration of care, looking at no-shows, accuracy of assessment, symptom outcomes, quality of care, services, cultural access, you name it. These are all metrics that you can utilize to establish the effectiveness of your telehealth program. It gives the metric, it describes it, and it tells what those outcomes are going to be for you. I like to promote the telehealth resource centers as they are also HRSA funded. And our motto is we are here for you. There are 14 of us, 12 across the United States. Unfortunately, none of the HRSA regions, no matter what the program, they never line up. So our 12 regions don't line up with your 7, and none of the other HRSA programs do either. But roughly speaking, this kind of covers most of them. That's the Southeast Telehealth Resource Center. I'm involved with them now. I'm also still involved with the Southwest Telehealth Resource Center. Please, please reach out to them with any questions you have about telemedicine. We also have one specifically dedicated to technology and one to policy. So if you want to know what the laws, regulations, and whatever the Senate or legislation in your state is doing, you can contact any one of the resource centers and we'll contact CCHP for you and find out what is going on in your state. Our goal is to provide support, guidance, advice as much as possible for free. If we get into more complicated stuff, it does get, there are prices involved and so on. Online, we have modules, and you can get just about any aspect of your telehealth program. All of the TRCs have stuff like this. We also have monthly webinars on a whole variety of topics about telemedicine. A number of them have been on telegenetics. They're every third Thursday of the month, except for this month because nobody's around, let's face it. All the TRCs participate. All the past ones are on the website. As I said, a couple have been genetics. So in order to go mainstream, like I said, that telemedicine train has already left the station. It's not a steam train anymore, it's a bullet train. It is the future. All the legal and reimbursement barriers that people always talk about are going to fall. New ones are going to come into place. I mean, you know, it's the government, let's face it. One of them in particular about data responsibility and remote monitoring and so on. Technology is going to morph. It's not going to be these big clunky systems that are used. We're going to have more wearable and implantable sensors, automatic training and communication, feedback, and so on, and we're going to have an EHR that works. The key, I think, to any telemedicine program is not the technology, it's the people. You've got to have the right people in place with the right skills, and you've got to integrate telemedicine into what you're doing naturally. It can't be, oh, let's do telemedicine and go down the hall because there's a special place to do telemedicine. Integrate it into your current workflow. And eventually, AI, clinical decision support tools are going to be the reality, and hopefully it won't look like this, because this is what we're doing now, but it will be something that really does improve patient care. Again, access to everyone, anytime, anywhere. So, thank you. I don't know if we have time for questions.
Hello, Dr. Krupinski. Thank you. I'm Shabana, a genetic counselor. I do pediatric telegenetics. So thank you. That was a great talk with a good overview. And I especially like that you covered the topic of holding telegenetics to a higher standard as far as outcome. Why is it that we have to demonstrate better outcome for telegenetics rather than an in-person visit? So thank you for bringing that up. I wanted to comment on one of your slides where I think it said telegenetics may not be wise for 3 conditions. You mentioned neurofibromatosis, Beckwith-Wiedemann, and hemihypertrophy. So speaking, for those of you who didn't attend the morning session, I've done about 700 sessions with a geneticist by telemedicine. And the one thing I may comment on is neurofibromatosis, cutaneous lesions. Actually, you can see better with the level of magnification that we have currently. So NF is very amenable. NF and other conditions that overlap with that are all very amenable to a full physical exam with informed consent, HIPAA encrypted lines and everything. So it is very amenable. Of the 700 cases we have done, only 3 cases where Dr. Schaefer, the geneticist I work with, said he didn't feel comfortable making the evaluation was a hemihypertrophy, but that was over 700 cases. Now, we didn't measure that. We've done it, but we didn't measure it, but that's our perspective. I don't know, Dr. Anderson, Dr. Zori, if you're here, if you could comment on to that or add to that.
Yeah, and a lot is going to depend on your experience. So you've done 700, and that's helped add to it. A lot also has to do, to some extent, with the quality of your cameras and the facility with which you can look at things. Taking pictures flat on, you're not always going to get the same thing as if you take it orthogonal, and so you can see the difference in elevation in a sense. So a lot of it has to do, again, with training people in particular. And how comfortable people are with the various things. But yeah, I think at some point everything is going to be able to be done by telemedicine, because there's also these gloves you can wear that you can palpate virtually. We just have to get them better, but that'll get there too.
So that was a great overview. Hans Anderson from Tulane. We've been doing telemedicine, telegenetics for 10 or 15 years now.
Mm-hmm.
It feels to me like we're spinning our wheels a lot. And I imagine this is not unique to genetics, and you've probably seen it in lots of different. Can you say one or two or three like major principles that we're getting wrong, or that, what are we all doing wrong that this is not easier?
It's not that we're doing it wrong. I think part of the problem is one of the things that you talked about this morning, which is just turnover in personnel. And that's a huge barrier, because if we don't start to train people earlier on the fact that telemedicine is not different, that's what I meant about integrating it into the curriculum. Get students to be doing this as part of their natural training. And it's not going to be, oh, we have to do the telemedicine rotation now, blah, blah, blah. It has to be part of what they're doing. And if we get them comfortable.
Everybody has to be comfortable doing it.
Exactly. And I think that's absolutely the key. It's all human factors. It's not the technology. It's getting the experience in there when they're young, when they're being trained. Trying to train somebody who's your 80-year-old provider isn't going to work. Okay, when teleradiology, which is probably the most advanced specialty, when we tried to get that out there, 30 years ago, 35 years ago, we just focused on the young folks, because the older radiologists, we just said, okay, and they went and they retired. Now, I'm not saying that that's the only solution, but let's face it, that is one inevitable thing that's going to happen. And our generation that's coming up now have such a facility. I mean, they'll whip out their phones and talk about just about anything with anybody using FaceTime, and they're used to just these funny little, making stupid faces at each other. But that's what it takes, is that facility with being able to, just do this all the time, that a lot of us simply did not grow up with. And it's not natural. And that's why, finding that champion really should be someone who is comfortable with all of this. But again, a lot of it, especially out in the rural areas, the main thing we had in Arizona was we would have, the folks on their J1 visas rotating in and out, in and out, in and out, and we'd have to retrain every 2 years. Oh, you're going to be there 2 years. Well, it takes 6 months to get people up to speed. Then they got to do their telemedicine. There's a year shot, and they're going to be gone in a year. So that's more the problem than anything else and going wrong. It's more a symptom of our healthcare system now in general.
I hear you say we're in a transition period that's going to take 10 years or so.
Hopefully not that long, because we've been saying 10 years for 20 years now, to be perfectly honest. So I honestly think that, barring the next 3.5 years, healthcare has got to get better at some point. We got to have the support from CMS and everyone else to just simply say, look, we're going to support